So I am Sindhu, and I'm currently a pediatric epilepsy fellow at Austin Hospital in Melbourne. And I'll be joining home soon, probably a couple of weeks, if not a couple of months, sort of thing. And I basically am mainly doing pediatric epilepsy here. And today I will talk to you about preventive treatment of epilepsy in tuberous sclerosis. This is a topic that's quite close to my heart. I've done a bit of work with some colleagues back in Malaysia, which I hope to continue on once I come back. And I would like to share with you all how you picking up tuberous sclerosis can make a difference to the outcome, especially in terms of the intellectual abilities and epilepsy care of these patients down the line. Can I have the next slide, please? So the outline of my talk is basically divided into three main sections, and I do feel we'll be able to cover it with the time that we have left. And so first of all, I'd like to apologize for the delays. I've had some issues sharing my slides. We'll talk about tuberous sclerosis and how to diagnose it first, which I'm fairly sure all of you from the pediatric world are fairly familiar with. And then I'll go on to talk about epilepsy in tuberous sclerosis and how we can almost prevent epilepsy in tuberous sclerosis and preserve the intellectual capacity of these children. And I'll take some of the questions at the end of the talk. Can I have the next slide? Thank you. So tuberous sclerosis complex, or what I'd be referring to as TS or TSC, basically mean the same thing, TS and TSC. It was previously known as Bournville-Pringle disease, and this is after two clinicians, Desiree Magloire Bournville, who was a French physician in the 1800s, and James Pringle, that's the image below. He was a British dermatologist, and they made a couple of observations and came up, the international world then coined this term Bournville-Pringle disease to talk about this manifestation where you actually have tissue overgrowth in multiple organs. So it could be the brain, it could be the skin, it could be the kidney, the heart, the eyes, lungs, and liver. And some patients may have just a portion of it, and some may have a more comprehensive manifestation. Next slide, please. So so this is basically an image. On the left, what you see is the PhD work of Bournville's PhD student, Joseph Thibault, and they were actually talking about pathology specimens of the brain, where you can see this very irregular lumps on the brain surface, and these are actually your cortical tubers. And around the ventricle, the middle picture is actually a sagittal cut through the middle of the brain, and you can see around the ventricles in the middle there you have these very rough bits, and those are your subependymal nodules. So even from the 1800s, they've actually made this connection that these patients have something going on in their brains. They have all these growths and things like that. And then they collected more and more evidence of other organ involvements. And that's how this whole thing became a multi-systemic organ involvement. Can I have the next slide? Thank you. So this is actually a criteria of TS diagnosis from the 70s. This was from 79, and this classification sort of lasted for about 20 years to 30 years. And you can see the primary criteria, you only needed one, and that was like either a cortical tuber or subependymal hematoma by pathology examination. This was because back then we didn't have much of MRI or CT scan examinations. Multiple retinal hematomas, so these are growths in your retina. Adenoma sebaceum, or periungual or subungual fibromas. So these are on your nail sort of thing. You get growths, these fibrous plaques, and you only needed one for the diagnosis. And then you had a secondary criteria. And you can see this is a mixed match of a bunch of things. Infantile spasms was one of it. Hypomelanocytic macule, Sjogren patch. If you only had a single retinal hematoma, or if you have CT that shows, intraventricular tuber or nodular calcifications on cranial CT. So they still felt that if you looked at the brain physically and you saw it, that would be a primary criteria. If you saw it on imaging, they would consider that secondary criteria, probably because of resolution of imaging back then. You would still have quite a number of differential diagnoses, so they were a bit more cautious. And then, of course, kidney involvement, cardiac rhabdomyoma, and also immediate relative with TS. That would be a secondary criteria. And you need, if you don't have any of the primaries, then you need 2 secondary criteria to make the diagnosis. Can I have the next slide, please? So today we use what is called the Northrop diagnosis, and this is, I think, 2012. What we do here in Malaysia is we use clinical diagnostic criteria. So part B onwards, we divide it into major and minor criteria. And in some places, you may send off someone for a genetic test. And this is not a karyotype. This is more of gene sequencing, either a WES or a gene panel. So part A says that you either have to have a gene mutation in the 2 genes, TSC1 or TSC2. And if you're doing a clinical diagnosis, then you have to divide them into major and minor criteria, similar to the Gomez criteria in the 70s. And the major criteria would be a hypomelanocytic macule. You need 3 or more of them at 5 mm or more. Angiofibromas, these are things, little fibrous plaques that you see anywhere at all. You need 3 or more. Ungual fibromas would be on the nails. Sjagren patch, usually at the back, lumbar region, and sometimes can be small, sometimes can be large, and sometimes can come on after a couple of years. You may not see it as a neonate or infant, but age 7, age 8, you may start seeing it. Multiple retinal hematomas, cortical dysplasias. Now, these are basically things that you see from a CT or an MRI, subependymal nodules. And some of the subependymal nodules, if they are at the foramen of Monro, they can grow into a SEGA or subependymal giant cell astrocytoma. The location of the subependymal nodule is what leads to the SEGAs. You have cardiac rhabdomyoma and angiomyolipomas, 2 or more. There's also criteria number 10, which is lymphangioleiomyomatosis. These are basically lung tumors that usually happen in females after the age of 25. I'm not sure why females, but they seem to have more of this. So in the adult population, if you have a TS patient with a chronic cough, X-ray is warranted and you may need to proceed with a CT. We don't see this in the pediatric population as much. Minor features would be confetti skin lesions. So you usually see them on the forearm, just little whitish spots. Enamel pits on the teeth. You can have intraoral fibroma. So on the gums and all that, some fibrous plaques. Renal cysts, retinal achromic patch. So on the retina, you just see a patch of no color at all. And non-renal hematomas. These are minor criteria. So can I have the next slide? So a definite diagnosis would be 2 major criteria or 1 major criteria with 2 minor, or you call it a possible diagnosis if you only have 1 major or 2 or more minors. So in TS, when we look at the clinical diagnosis, we divide them into either definite or possible, depending on how many major and minor you have. And this is a classification that's available even on the TS Alliance website. So can I have the next slide? I will move on to what the incidence and the inheritance is. So first things first, I will explain this in the next slide. So the TSC1 gene codes for a protein called harmatin, and the TSC2 gene codes for a protein called tuberin. So if you have a defect in either TSC1 or TSC2, then you will have these tumors growing all over the place, and we call you a TSC, either definite or probable, depending on your major or minor criteria. What you need to know is that between the 2 genes, TSC2 mutations that lead to tuberin dysfunction are far more serious in terms of their implications compared to TSC1. You can have a TSC1 mutation, have TS and not have epilepsy, not have a lot of the major life-threatening combinations. But with TSC2, it's usually more severe. There's much more intellectual disability. There's much more epilepsy. And if you take 100 patients with TS, 2/3 of them will be de novo. So only in 30 of them, you would have a family history. In the 30 of them with family history, there's an even split between TSC1 and TSC2. But for the de novo guys, which make up the bulk of your TSC patients, they often have a TSC2 mutation. What that means is if you take 100 patients with TSC, more of them will be more severe compared to minor, because more people tend to have TSC2 mutation, and tuberine dysfunction is more pathological compared to TSC1, which is why when you see a TSC patient, they vary in their presentation. Some may be going to normal school and some completely may need additional support. So it's still a rare disease. Incidence in the UK studies was about 1 in 6,000, and I think also did a bit of an incidence study. We are about around the same here in Malaysia as well. Can I have the next slide? So I want you to focus on the colored image. Don't bother about the words that I've put up there. So here is just a slide to kind of explain to you how this thing works. Now, you see the bits in yellow, that is what we call the mTOR complex. mTOR basically promotes tissue growth, okay? And above that mTOR complex is a Reb. Reb is a protein that functions to activate the mTOR complex. When you have TSC1 and TSC2 genes functioning properly, they inhibit the Reb. When they inhibit the Reb inhibits the mTOR, you don't get overgrowth. But if your TSC1 is not working or your TSC2 is not working, then you cannot inhibit Reb goes out of control, and this activates the mTOR complex and you start getting tissue growth all over the place. That is the pathogenesis of TSC. So TSC1 and 2, either one of them don't work. Very rarely is the TBC1D7. More often in TSC patients is either TSC1 or 2, and between 1 and 2, 2 is more common in terms of dysfunction. Then Reb cannot be suppressed, so Reb goes out of control, and then mTOR goes out of control, and you start getting tissue growth here and there, something like a malignancy, if I may put it that way. And often these tumors are, often these tumors are benign, but some of them can undergo a malignant growth, especially in the kidneys. Can I have the next slide, please? So I move on to the next part of my talk, which is epilepsy in tuberous sclerosis. So you can have 100 patients with tuberous sclerosis, and you'll find that epilepsy is the most common neurological symptom of TSC. More than 3/4 of patients, so more than 70% of these patients with TSC tend to have epilepsy. And what is important about this epilepsy is most of them tend to present when they're really young. In fact, almost 2/3 of them by the age of 1 and 82% by the age of 3. And this is a combination of work by Italian groups led by Curatello, Chushaw, which is a French group, and as well as Jozwiak, which is a Polish group, which actually spearheaded a lot of the preventive treatment management in TSC epilepsy. Can I have the next slide, please? So in this seminal work where they looked at almost 300 patients from France with TSC, 85% of them had seizures, and seizures don't mean epilepsy, but when it's TSC, often when you have a seizure, almost 100% of them went on to develop epilepsy, meaning that most of those patients that had seizures, 85% of them, out of that 85%, almost 100% of them went on to develop epilepsy. And out of this group, 2/3 of them were drug resistant. So the numbers are big. Most of the time, more than 80% of the time, if somebody has TS, there's a high chance they will have epilepsy. And out of this group that developed epilepsy, almost 40% had infantile spasms. And the most common seizure age is actually in the infancy period at 3 months of age. And when you have infantile spasms, naturally, most of them tend to have cognitive impairment. And even in the group that didn't have infantile spasms, about 40% of them go on to have cognitive impairment. And most of the patients that have their epilepsy before the age of 3, which is the bulk of your TSC patients with epilepsy, they have cognitive impairment. So it kind of tells you that most TSC patients have epilepsy. When they do have it, they have it really young, and most of them go on to have intellectual disability later on. Can I have the next slide, please? So this is just a pictorial to just remind you that when you have a patient with TSC, high chance that that patient is either having or going to have epilepsy. Next slide. So I want to talk a bit about vigabatrin because you would know as pediatricians and pediatric medical officers and registrars that whenever we talk about infantile spasm, we basically harp on prednisolone and vigabatrin. These are your two first lines. So vigabatrin was a drug that was initially licensed as a focal epilepsy management in adults in the 90s. And in the late 90s, they used it for infantile spasms, and they found that it was really helpful, especially in patients that had epilepsy, infantile spasms secondary to tuberous sclerosis. And by 1998, they had already decided that if you have a child coming in with infantile spasms and you find that the child fulfills the criteria for tuberous sclerosis, Viga is your first line of management. Can I have the next slide? So what Viga does is, in the brains, we have excitatory neurotransmitters and we have inhibitory neurotransmitters. With this too, if you have too much excitation, either overproduction of the excitatory or underproduction of the inhibitory, it tips over the balance into an excitatory mode and you start having discharges of neurons being synchronized and leading to seizures. What vigabatrin does is, and you can see from the name vigabatrin, it actually has a GABA in there. What it does is it increases the pool of inhibitory GABA, and inhibitory GABA suppresses the neuronal activity and therefore controls epilepsy in that way. And that is what vigabatrin does. Instead of GABA, once it's being released, usually the body will tend to kind of disintegrate it and it will disappear. This neurotransmitter is accumulated. Its disintegration is prevented and it accumulates. And so you have more inhibitory neurotransmitters, and that reduces the balance and the probability of you having seizures. Next slide, please. So in the animal models, and this is what we do in some of the labs here as well in Melbourne, we have mice and we're able to engineer and knock out certain genes in them or amplify certain genes. So in the knockout mice, you take off TSC1, you dysregulate it. What happens is REP goes out of control and mTOR goes out of control and you start manifesting TSC, and these rats tend to get epilepsy. And when they use vigabatrin in these rats, once they knocked out the gene, the seizures actually reduced and also their survival improved. And what they find is when they measure the GABA pool in certain areas of the brain are increased. And one important study by Zhang's group in 2017 proved that the vigabatrin actually reduces the mTOR activation. So it's not just about the GABA. What that sentence means is that this drug actually has a disease modifying capacity, and that is different from other medications. For instance, let's say you have hypertension and you use a beta blocker like say atenolol. It reduces your blood pressure, but if you stop taking the medication, your blood pressure goes up. That's what most anti-seizure medications do. When you stop taking medication, the seizures come back because what the drugs do is they try to control. But for TSC, vigabatrin actually has a disease modifying capacity because it actually regulates even the mTOR activation. And there are very few drugs that actually work this way. One of the other drugs that we use that has a disease modifying capacity is actually the mTOR inhibitors such as everolimus or sirolimus, which you may know more from the renal world because they use it for the angiomyolipomas and things like that. In some centers like and all, they actually have everolimus for SEGA. So you eat your everolimus, keep the TDM within range, and what it does is it actually can shrink the tumor and prevent it from getting bigger. And it actually modulates rather than just suppressing kind of thing. So can I have the next slide? So the Italians were the first group in 2010 and 2011 to release papers to show that the sooner you start vigabatrin for patients with TSC who have either infantile spasms or focal epilepsy, the better the development and the seizure control. So can I have the next slide? based on this information, the thought became, if we can actually diagnose TSC early, which we can, you have skin manifestations that make you suspect it. Some of them have a family history. And the next bit is, if early treatment can actually improve cognitive outcome, can we actually do more for these patients? And can I have the next slide? And this is what led the Polish group in 2011 and 2012 to actually start this anti-seizure medications for those that they have diagnosed with TS. And even before you start having your epilepsy, as long as your EEG shows abnormalities and the abnormalities are quantified to be a significant amount, they start giving anti-seizure medications in the form of vigabatrin, and they want to then look at the outcome. This started more than 10 years ago by the Polish group based on the Italians' findings that the earlier somebody comes with infantile spasm, let's say somebody starts at day 7 post-infantile spasm and the next fellow starts at 1 month post-infantile spasm, get treatment. The ones that start early have a better outcome, and these guys took it and gave the parents the option. Your child has TSC. We are seeing things on the EEG. Would you like to start now, or would you like to start once the epilepsy is there? And they published their results. Can I have the next slide? And so in this initial group of it was open label. Everybody knew who was on treatment, who wasn't. So standard treatment was wait for the seizures, and preventive treatment was before your seizures start, as long as your EEG is bad, we start it for you. So from the diagnosis, every 6 weeks they had an EEG, and they did the development scores and the seizure epilepsy evaluation at the age of 2. And then they wanted to look at, if you were in the preventive group, did you have seizures? If you did, what age did they come on at? What was the level of drug resistance? What types of seizures were there? And did your EEGs revert back to normal if we started the treatment earlier versus later? Can I have the next slide? And these were their results. So I have kind of put standard is when seizures start, preventive is before the seizures start. And you can see one of the things that jump out the most is the mean IQ score. For the standard group, mean IQ score was 68.7, which actually puts you in the mild intellectual disability category. And for the preventive group, there were only about 14 of them versus 31 in the other standard group. The IQ score was 92, which is actually average intelligence. It's not even mild intellectual disability, and that's where your P values kind of jumped off. You can even see for other things like seizure freedom, the preventive group actually had seizure freedom for a longer period, and that was statistically significant as well. Can I have the next slide, please? So this led to a global, study called EpiStop, basically trying to stop epilepsy. And they were recruiting from 2014 to 2018 in a few countries, 10 all in all. And in some countries, they had ethical approval for randomized control. And in some countries, it needed to be open label. But basically, 94 children completed either the open label or the RCT group, where they divided these children into preventive versus standard treatment. And what they did was they would measure the EEGs at regular intervals and also the developmental scores, and then they want to see whether they're adverse events when you're treated and versus you're not treated, and try to give you a better picture overall as to whether preventive treatment actually makes a difference. Can I have the next slide? And so you can see here, regardless of whether it was the RCT group or the observational group, those that had preventive treatment are in blue, and those that had standard therapy are in red. And you can see what they show, what this graph shows is on the x-axis, you have age. So 360 is 1 year, 720 is about 2 years of age. And on the y-axis is percentage of seizure freedom. So as the babies are really young at 1 month and all of that, almost all of them, 100% of them have seizure freedom, meaning they don't have seizures. But as they grow older, the natural history is that more and more of them have seizures, that if you're not treated, by the time you are 2 years of age, 85% of patients have seizures. The seizure freedom is only 15%. And this is for both, whether you're RCT or open label. Okay. And in the preventive group, you can see that at the end of 2 years, about 50% of them remain seizure free. Okay, can I have the next slide? Thank you for the cursor. and so now this EpiStop group is not yet able to publish IQ results because at the end of their study period, most children were still, really young. But I do expect in the next, 2 or 3 years, we will see the IQ discrepancy between standard versus preventive. But I'm talking now back to the group of the Polish group that in 2012 did the first round of preventive treatment. They came up in 2018, 2019 to give you a, a, a review 10 years down the line of those patients that they initially studied, where they looked at seizure freedom. They did an IQ test, and years down the line, they're giving you, now let's look back at those guys and see where they are at. And you can see the standard group is basically the group that didn't have preventive treatment. And the preventive group is the group that had that vigabatrin even before seizure started. And you can see that those IQ results are still significant. In the preventive group, you're looking at average intelligence. These are people that can go out, get a job, go to school, and function independently. And 46 is now what we call moderate intellectual disability. They are not able to care for themselves. You can see even the number of patients with epilepsy versus in the standard and preventive groups are different. With 50% of the preventive group maintaining seizure freedom versus the standard group. And it's basically showing you that with early intervention, what happens is that you have a much better IQ outcome, you have a much better um, um, epilepsy outcome. And the reason for this is in pediatrics, we know that an injury to the brain depends on which part of the brain, but also at what point in development. And you and I both know that the first 3 years are the most instrumental years. If you have a traumatic brain injury in infancy versus when you are 9 years old, if the severity is the same, the outcome is usually far worse for the child. There is this idea of plasticity. I am very well aware of that. But when you preserve a brain that is developing so fast for the first few years, that investment pays off much more than if you weren't to preserve. And that's the whole purpose of preventive treatment in TS, because you can pick up TS early. Clinicians do it all the time with a keen eye. And if we can do what we can to monitor these brains and see, hey, this brain is looking very active, I think we should offer this treatment and get somewhere. That is what we are trying to do, which is very different from the previous thinking or the current thinking in other areas of epilepsy, which is you establish epilepsy first, then only you treat. If it's just a single seizure with a very low recurrence possibility, you watch and wait, and that still holds. But TS is a different kettle of fish simply because the outcomes actually differ when you start early. Can I have the next slide, please? So if you're thinking, yeah, but what if they don't have seizures and then you treat, what will happen? What about side effects and all of that? The first study that I mentioned to you, they didn't actually talk about this, but later on when they published their cohort, 10 years down the line, they actually did say there was no therapy-related adverse events. The EpiStop group didn't have any out of the 94 that had therapy-related adverse events. So it is a fairly safe treatment to start in the name of protecting the child's IQ. And can I have this slide? Yeah, the next slide. So the question is, can we pick up TSC children before they present with epilepsy and your autism and your behavioral issues and things like that? And I think the answer to that is yes. You are all good clinicians out there that, do your clinical exam and you pick up half the symptoms from the skin itself. You have easy access to ophthal assessments. Echocardiogram is an appointment away, and all these things can be done. And in children, we also do renal ultrasounds, which can be done in most of your setups, either with an appointment, which is usually non-urgent. Can we preempt the onset of seizures? The neurology team is able to do this. If the children have regular EEGs, we can actually see which child is moving towards epilepsy or towards infantile spasm for that matter, because the EEG does give us certain signatures that we are looking for. And can we alter the outcome? And I think the answer is yes, we can alter the outcome, especially if we go towards preventive treatment, or if we are going to wait for seizures, the sooner we start, the better the outcome. So I do think, yes, we can alter the outcome. Can I have the next slide? So here's a bit of work that we did initially in HTA, and then we spread it across the country. So what we did is we engaged the fetal-maternal specialists, and we said, hey, if you find a cardiac rhabdomyoma, can you just, confirm, get the team to confirm that upon delivery, and then we let the neonatal team contact us if they have a confirmed cardiac rhabdomyoma. The reason for this is because a lot of studies show that between 60 to 95% of cardiac rhabdomyomas are due to TSC. So you can have a rhabdomyoma without TSC, but the chances of that are very low. So it's a very good non-invasive screening test. And so the neonate team would also get back to us if any of the neonates have a family history, either a parent or a sibling with proven TS, and any infant with a suspected TS, the pediatricians. So what we ask is for a full workup. Look at the skin, get an MRI brain. Yes, even if they're 1 month old, get an MRI brain, because the MRI brain shows the tubers and the subependymal nodules. Usually in the infants, you don't yet have SEGA, but after the age of 1, depending on that location of that subependymal nodule, they can grow. And a cardiac echo, which is what we ask all of you to do. And if it fulfills the criteria, sometimes you would say the MRI is only going to come in 4 months. And what we'll say is like, look, if there's a cardiac rhabdomyoma and there's a skin lesion or a family history or whatever, let's presume and start the EEG surveillance. What we did was, for the first 6 months, we did EEGs every month. Yes, the patient had to come in as an outpatient, get the EEG and go, and we would read that. And after the first 6 months, we did every 2 months once. And after the first year to second year, we did every 3 months once. And what we were looking for is whether or not there were any EEG changes to suggest either this child is going to go into hypsarrhythmia or the focal discharges are getting more. Next slide, please. Thank you. So this is one of the patients. She had her first MRI at 2 months old. She was initially picked up with the cardiac scan showing rhabdomyoma in utero, which was confirmed ex utero. We got the MRI scan at 2 months of age. It showed subependymal nodules. There were tubers all over the place, bifrontally, left temporal. There were also radial migration lines. These are just just a linear line between the cortex and the ventricle region sort of thing. And it's very characteristic of cortical dysplasia, especially of TS. So her first EEG at 1 month, 2 months, and 3 months was normal, but at the age of 4 months, we started to see multifocal spikes all over the place. These tubers were already starting to discharge, right? So we counseled them, we gave them the option, we can wait and watch, or if you want, we can go on to preventive treatment. And we started them on vigabatrin. And we optimized that to 66. If you're wondering why 66, is usually because the tablet needs to be cut in a certain way. And so the tablet's about 500 milligrams, half of it would be 250, and then the next quarter would be 125. So somewhere around there, we've picked our doses according to how we can cut it. And she had a dose of 66 milligrams. Maximum dose is 150 milligrams per kilo per day. Can I have the next slide? This is just showing you her MRI, and I've just pointed out some of the tubers. The radial migration line is where the mouse is right now. The tubers were the frontal region. All over this place, those little white blotches, those were her tubers. And this is quite a heavy load of tuber in her. Can I have the next slide? I'll show you her EEGs. Now, I don't expect you all to understand very much, but this is a nice quiet EEG at 2 months of age. There are a bit of sleep spindles. The blue side is the right side, the red side is the left side, and you're looking at the middle parts as well as the side portions. Can I have the next slide? So this is once again another sleep EEG when she's 3 months old. We were not too worried about this. They were looking nice for the most. These are all sleep spindles. Those beautiful fuzzy looking things are what we call sleep spindles. When you read our reports and we say sleep stage 2 was achieved as evidenced by K complexes and sleep spindles, these are the fuzzy things that we're talking about. In a neonate and an infant, you can have asymmetry. That's normal. By the time they're 1 year of age, they're often quite symmetrical. And if they're not symmetrical, that indicates a pathology that's affecting one side more than the other. But at this age, this is beautiful. Can I have the next slide? So now at 4 months, you start seeing a much nastier picture. You still see those fuzzy looking sleep spindles at the bottom right hand side, but you see a lot more spiky looking guys on both the left side of the brain as well as the right side of the brain. And she hadn't yet had seizures at this point, but we said this is significant. Even in one page, you can pick out quite a number of them. And so we counsel this family for preventive vigor, and they were happy to come on board. And can I have the next slide? So we started that vigor, and now you see at 5 months, we're going back to that pattern of nice, seamless. Yes, you can see the sleep spindles, but you don't see those nasty guys anymore. This girl had normal development at one age. When I left for my further studies, she still maintained normal development at about 1.5 years old, and we would have done a Bailey's development score for her at the age of 2 to see how she was doing. Right? Can I have the next slide? So this is basically in the red bits information that a colleague from mine, Dr. Rohaya, who is currently a pediatric neurologist in Terengganu, she had compiled this information from our TSC clinic cohort in HTA. And we had 34 patients in that clinic, so all of them having TSC. And almost all of them had epilepsy. Now, this can be a bit of a biased sample because we were running the epilepsy clinic, and that's where these patients are coming from. So chances are they will all have epilepsy. But if you remember my previous slide, 72% of patients at least with TSC do go on to have epilepsy. From this cohort, 97% of them had their epilepsy before the age of 3. Half of them had infantile spasm as their presentation. 43% of them had drug-resistant epilepsy. 1/3 of them had cardiac rhabdomyoma. And at the moment, a good 1/3 of them have cognitive delay and behavioral issues. And I need to remind you that this is us, the neurologists, making an assessment. I'm pretty sure the developmental team or a neuropsychologist with pediatric capacity did the test, you will have a lot more cognitive issues that are picked up, because we pick up the gross things, they pick up the much subtler things within the various domains of attention and perception and speech and language and things like that, which we are not so good at doing. Ours is a far more gross estimate. So these were our numbers in 2020. And if we were to apply that preventive results to our cohort, what you would be seeing in 2030 are a much lower number, none with infantile spasms, probably just 1/4 with cognitive delay. And this is with neuropsychiatry, not just the neurologist's gross assessment. And half of them having epilepsy versus almost 100% of them. And you can see the numbers are quite encouraging. Can I have the next slide? Okay, so the one drug that I didn't talk about is everolimus. Sirolimus is another one, but we generally have more studies on everolimus. This is available in Malaysia, but is extremely expensive. At the moment, as I said, the onco team in, I think, has it for SEGAS, and also the renal team might have it for angiomyolipomas. They did a study, the French group, they exist 3. They divided patients into 3 groups: high dose everolimus, low dose everolimus, and placebo group. And you can see that the seizure reduction was almost 1/3 for those with low dose versus high dose, 40% of that. I was very interested. I am always interested in placebo effect. How do the placebo guys get a 15% reduction? I'm not sure. I can't explain that just yet, but this is this is a precision therapy, more precision therapy than vigabatrin, but cost is a factor for us. At the moment, we can't afford to give this as preventive. But I can share with you my experience for a patient with a very drug-resistant TSC, epilepsy with behavioral issues and autism, who was one of my patients in HKL. HTA. She developed renal angiomyolipoma, and so we referred her to the nephro team, and she got everolimus, and we tried all sorts of things for her epilepsy, and nothing worked. And they started everolimus, and her seizures just melted away. So we took off all the other medications, and we said she just keep her on everolimus for her angiomyolipoma. We share the benefits. Can I have the next slide? Yeah. So I am from quite an older generation. This movie came out when I was actually in high school. This is the Matrix trilogy, where it's a fantastic movie and quite a deeply philosophical movie as well. If you've not heard of it, it clearly tells me what my age is and what your age is. But basically, what happens in the movie is that Neo is offered either the blue pill or the red pill, and you take one of these pills and life goes on as status quo, and if you take the other pill, it's an alternate reality which is considered to be the real world, and he decides to take the alternate reality, and that's where the whole Matrix trilogy comes from. And I feel like we are at that point where today we can offer these children more. We can actually offer them preventive treatment. There's not much side effects at all related to the therapy, but we get much better outcomes in terms of epilepsy outcomes, as well as their intellectual capacity and their abilities to lead independent lives. And I think that this should be the way, not just for TSC, but for a lot of other disorders. But the beauty about TSC is we can pick it up early, which with some of the other disorders we are not able to do. In some centers in Europe, America, and even Australia, we're starting to do genomic screens, like whole exome sequencing or whole genome sequencing as soon as a baby is born, so that we're able to pick things that have these kind of preventive things that when you start early, you can actually preserve outcomes. It is a pilot project. I do think probably in the next couple of decades, hopefully in the next couple of years, instead of just doing cord blood for TFT, TSH, and G6PD, it will be a wider spectrum, because the era of precision medicine is now. It is, in fact, it is yesterday, and it is the future. And I hope that with this talk, I've able to impress upon you your instrumental role in getting us this patient, so that we can monitor and hopefully have a different outcome with time as we move forward. Thank you. I will take your questions. I think there's one in the chat box. Hi, Stephanie. How are you? I hope you're doing well. Stephanie was one of my finest colleagues when I was in Penang. So in a neonate with incidental finding of cardiac rhabdomyoma but without family history, is it worth to do the TS workup, including MRI, brain, and EEG? How about genetic studies? So that's a good question. I would suggest anyone with a cardiac rhabdomyoma, it would be worth doing a TS workup. And what this workup would entail in the pediatric age group is one, a renal ultrasound. Now, renal ultrasound, the guideline is you do it 1 to 2 years once, because the renal cysts and the renal angiomyolipomas come on with time. So they may not be there at the start, but if they are there at the start, it's not a good start. It just means it's a more aggressive. This is my personal observation. Please don't quote me on it. It's just what I noticed. The MRI brain is something that we do every 3 years once until the age of 20 to 25. The reason for that is after the age of 20 to 25, you usually don't get any more new tubers. So every 3 years, yes, you do an MRI brain. But for a child that's coming to you incidentally with the first cardiac rhabdomyoma, you do a skin assessment. Ophthalmic assessment, usually they don't find it so early, but it's worth to have a baseline anyways. You do a renal ultrasound and a single MRI brain. If that MRI brain doesn't show any nodules, subependymal nodules or cortical tubers, then just discuss with us. If the thing is a possible TS, we won't go on to EEG surveillance. If it fulfills definite TS, we will go on to EEG surveillance. I prefer to do EEG surveillance and then say no need anymore because you're a possible, not a definite, because at 3 months of age is the most common age of onset of seizures, and a lot of times parents don't pick it up that they are actually having focal seizures, because focal seizures can be as simple as a child just going blank for a while, and that could be a seizure, and parents may not recognize it because not everybody has a focal clonic seizure. Focal clonic seizures will come if you have a tuber around the motor strip or it propagates to the motor strip. If you have something at the front here, it may not give you a motor sign at all. So I would say yes, if, because the incidence of TSC is very high in the cardiac rhabdomyoma population, it is worth doing it's worth doing the screen, and then you decide whether it's actually probable or definite. During that probable or definite, if it's not too hard to start on EEG surveillance, it's worth it to start, because sometimes your MRI takes 3 months, 4 months, which is fair. Not every place can give you an early MRI or whatever, but the surveillance we can start early. And sometimes if we see abnormalities, we can convey to you that there are abnormalities, please push for an earlier MRI. That's number one. Do we do genetic study? We don't routinely do it because of cost issues and because you can clinically diagnose based on the other tests. But is it worth it to do? I do think it's worth it to do, because technically what we tend to do is, if there is a patient that we diagnose with TS, we actually send the family to the geneticist, because they may need to do a clinical screen for the rest of the family, which you can do at your level as well. Of course, having the genetic diagnosis, the particular variant, and seeing whether it's TSC 1 or 2 makes a difference prognostically. You can anticipate more issues if it's TSC 2, less issues if it's TSC 1. It is not a must, but it's good to do, but it will depend on the team's budget as well. If the team doesn't have much of a budget, they may put it in the weight basket later. We do once we have budget, kind of thing. It's good practice to do. I do think genetic information gives you a lot of added advantages, because you know where the problem is. You can tell then from there whether you want to screen the other family members to see whether it's a de novo or not. Some variants are so pathological that they know every patient with this variant would have manifestation, and if the parents don't have, you can kind of make a fair assumption that this is de novo, although it's best done with confirmatory genetic tests, if that makes sense. With limitation in district settings, when should we decide to refer to the neurology team? When there's suspicion of rhabdomyoma, it is hard to arrange for monthly EEGs or get an earlier MRI date. Yeah, you can discuss this with us, because it will definitely be case to case as well, depending on how difficult it is for the families to go for the EEG. The attrition rate in some places is quite high. What I mean by attrition rate is those that are able to keep up with this very intense monthly, then 2 monthly, then 3 monthly EEGs. Like in Klang Valley, most of our patients, maybe our counseling also was okay lah, but they came for every single appointment, and also because they get to see us, and we also see that the child is not having any seizures, developmentally coming on well, and things like that. If you have a cardiac rhabdomyoma, I would advise you to discuss with your radiologist for an elective MRI and an elective cardiac scan, and a renal ultrasound. If they're not able to come for EEGs and all of that, then discuss it with us, because we'd be happy to say, okay, maybe if three months is a possibility, can they come 3 months once, and then we take it from there. So basically, something is better than nothing. I'm not going to say there's of course there's a guideline. I wrote that guideline, but that is in an ideal situation. There will be families that are living right smack next to the MRI machine and still not be able to make it, and I understand that, but whatever we can, we try. And that's the whole principle, which is similar, I suppose, in other areas of pediatrics. what is the earliest age for us to do an EEG? Can we do earlier than 1 month? Yes, we actually have neonatal EEGs. Sometimes neonates have very bad seizures, as whether it's due to stroke or things like that. Neonates also have EEGs. In HTA, we used to start at 1 month, but if the patient was going to go far and then not be able to come, then we will just get one done there. For what it's worth, we try to do it opportunistically, but you don't need to do it at a neonatal stage, because the baby usually has other things going on, and we know that the most common age of presentation, the earliest, is 3 months. So you have a bit of time lah. Yeah. I hope that has answered those first few questions. What is the best age to do MRI? Is yes. Okay, I understand this argument. Is earlier better? In some radiology says myelination is not complete. I agree. So the myelination is complete at 2 years and above, and I do know that in some radiology centers, they would advise you to do after the ages of 2 or 3. But I think the question here is, what are you looking for? Right? If you want in a global developmental delay, a child is already coming to you at 18 months of age, I'd say just wait another 6 months. You'd get a better picture where you don't have to repeat it again because myelination is complete. If the myelination at that point has some issues, they will suggest a follow-up to decide whether this is a dysmyelination or a hypomyelination, and that will give you a different set of differential diagnosis. But in this situation, we are screening for subependymal nodules and tubers, which can be there from birth, which can be there as early as neonatal period. So you don't have to wait for myelination to complete, because in this patient, the myelination doesn't give me any added information. I would expect an MRI at 3 months old to have non-complete myelination, but I am looking for subependymal nodules and tubers. So in this situation, the age doesn't really matter. So it all matters what you're looking for. If you're doing it as part of a general screening kind of thing, then it's fair to give it a bit of time. If you're looking for something specific, then it's fair to do it at an earlier point of time, especially in a situation where myelination is not going to make a difference here to my patient. Fatin Shahira, thank you. Is there a role of ultrasound cranium while waiting for the MRI brain? So the tubers are actually quite superficial. They're on the surface of the brain. Would I be comfortable calling this TS based on an ultrasound? I wouldn't. I think the criteria is based on MRI. But I would use the ultrasound if I have a patient that says I'm going away and I won't be able to come to you ever again unless I have a problem. Then I'll use what I have lah. But is it necessary if I can get an MRI in the next 2 to 3 months? In the meanwhile, my patient can come for a screening EEG, and the neuro team is happy to proceed with that. I think that's fair. I wouldn't bother with an ultrasound of the cranium, because I'd be a bit hesitant to make that criteria, that major criteria diagnosis based on ultrasound, because that one was pretty much based on MRI findings. I wouldn't do a CT scan just because I don't think it's worth the radiation. It's not an urgent thing. We just want to get a clearer picture. EEG surveillance can go on in the meanwhile. If the parents are agreeable, we can drop the whole project. We have had patients where they have presented with cardiac rhabdomyoma. Our thorough assessment, including ophthalmic, renal, MRI, all that was negative. And so we said no need to come anymore. Just GenPeds can just keep an eye on the development to see if there's any concerns every 6 months once or whatever, and if none, then they can just discharge from follow-up even from that. I hope that answers that. Child fulfill criteria but no seizure and normal development. Should we do MRI screening? The answer is yes, because TSC is an overgrowth disorder. You shouldn't just do MRI brain, you should also do renal ultrasound, because you don't know when they start popping up. And if they start popping up, you need to be on it earlier rather than later, because renal may start with a cyst, Within the next 1 or 2 years, you may have components of angiomyolipoma. Within the next 3 or 4 years, you won't be able to tell whether this is an renal cell carcinoma or whether it's a ruptured angiomyolipoma or all of those things. So the cognitively normal non-epileptic patients can still have these things coming up, and these are surveillance tools. When I ask you to do the workup, that is that initial workup, but after that, every month, oh my god, I'm over time, sorry, every month, every year, sorry, renal ultrasound, every 3 years MRI brain. I hope that answers that. Even if normal development, MRI brain until 20 years of age, renal, you probably need to continue into adulthood. Okay.
Thank you very much, Dr. Sindhu, and thank you for answer all the questions. Okay.
Thank you all. Sorry for the delay and the technical
No
issues.
problem.
Thank you.
It's okay. So now we would like to move on to our next speaker, Dr. Vicky. Yes, is Dr. Vicky online now?
Hello.